Good afternoon, everyone. Thank you for joining us. We're going to get started here in just a few minutes.
Hi, everyone. Welcome to our monthly webinar on trending beyond COVID-19. Welcome back. If you're just joining us for the first time, we're happy to have you. This is our third year in the series, so a lot of you have been joining us for quite a long time now. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare, and I'll be your moderator for today's session. The session is being recorded, and during the webinar, you will be on mute. Please submit your questions using the Q&A function in Zoom. We take all the questions at the conclusion of the formal remarks. The webinar recording will be posted on our YouTube channel in the next couple of days, and a transcript of the question and answer segment will be posted on our website. We'll share the links to those two resources with you during the webinar. We have a full hour scheduled today, and we should have plenty of time to answer all your questions. Our speaker, as always, is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He is a consulting medical director with WorkCare and has been very involved in all of our COVID-related activities and solution development. So now I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen. And thanks everyone to joining us once again. We recognize that we have been well into this process of trying to protect the workforce with regard to COVID-19 for quite some time. And we're starting to see, obviously, some very promising trends that look like and appear to be light at the end of the tunnel, right? And so we'll definitely dig into that today, but we want to introduce to you a new format. And apologies to the team because I'm calling the audible. You know me, I've done this before. And we want to switch the overall structure for this particular webinar to not just accommodate for as we continue to move through the pandemic, but we want to be, as always, forward looking as to what's next and on the horizon with more broadly occupational health trends. So we're going to rebrand this today in regards to our approach. Occ Health Trends is what we will focus in on as we have evolved from obviously COVID-19 focus when the pandemic began, trending beyond COVID-19, beginning to look at what lies ahead beyond a COVID-19 pandemic world for us. And now we're going to markedly move towards looking at Occ Health trends more broadly that we need to be cognizant of as occupational health professionals, as industrial hygienists, as ergonomic professionals, and obviously as health and safety professionals. We need to focus in on what are the trends that will impact our workforce and stay ahead of the curve. And that's what we're going to accomplish as we continue this series forward. So with that being said, again, our focus is going to be occupational health trends, new approaches to 360 workers' health protection. All right. And if you have joined us and have been joining us since the beginning, the format for this new evolution of this series might look familiar. And as one has said long ago, if it ain't broken, don't try to fix it. So we're going to do a little twist on the original, but the overall approach will be a clinical update of the Occ Health trend. We'll dig into the pathology of the Occ Health trend and try to understand the undergirdings of it. And we'll go over the epidemiology and workforce strategy. So as we give you focused content in these regards, we want you to be clear about the clinical presentation so that you can communicate it to your workforce. We want you to be clear about the pathology, not that we're going to make you professional pathologists, right? But understanding the health issues. Obviously, we are a group of professionals that have a background and training on health matters. So this will be appropriate content for our professionals that are joining us. And then, as always, we'll pull back, look at epidemiology, not just from the impact here in the US, but globally, right? So that we can accurately attack risk mitigation abroad as well as locally. And then finally, we'll discuss the strategy that we should have, best practices for workplace risk reduction regarding health issues and impact to our workers. So let's dig into it. So the first thing we're going to talk about, as no surprise, we're not out of this jungle yet, right? But we want to talk about COVID from an aspect of what's not being spoken to and what is likely to be the trend that continues that we've seen for quite some time now. And that trend is long COVID-19. Some of you may have not heard of this terminology before. Hopefully some of you have. But we're going to give you a clinical update as to what is long COVID-19. Let's describe its features of the illness itself, and then what are the possible impacts to your workforce. So let's begin to dig into this clinical update. And I promise you up front, we'll save time for questions, not just for this, but for other things that we need to discuss regarding COVID-19, wind down pandemic things of that nature as well. So COVID-19, long COVID, right, is something that we've heard terminology around some time ago, right? This article was published back in March of 2021, okay? Long haul COVID affecting 1 out of 4 individuals, regardless of severity. Right, so you've seen this most likely if you're familiar with the terminology long haul or long COVID. We'll go over some of the other terminology that's been used and circulated, but we want to dig into what exactly is long haul COVID or long COVID itself. In particular, this article that was published back in March 2021 defined it and looked at statistics of a quarter or even a third of individuals that experienced an infection of COVID-19 became long haulers, okay? And there were studies even back then that showed these numbers could be substantial. But if we look to define specifically, and this is important because there are multiple definitions out there around long COVID, we want to look to a couple sources here to try to articulate what exactly is long COVID, and then we'll share what our moving forward definition of long COVID should be for interpretation purposes. So WHO focused in on long COVID again, really in earnest, in December 2021, when they published this body of data, right? And they looked specifically at articulating long COVID, not just from the perspective of what's happening in the UK, but they did so more broadly to look at what is the overall consensus that the clinical community worldwide could arrive at, right? And so they put together and executed on a research project that began and was published October 2021 to clinically define long COVID. In this case, they use different terminology. Again, we'll talk about specifics here. And they went about this using a process called Delphi consensus. It's a validated methodology for capturing the consensus of a clinical issue. In this case, the clinical issue is long COVID, right? And so as we dig into exactly what their approach was and what they found, they used this research methodology, Delphi method, to incorporate in the process not just researchers, right, but patients, clinicians, external experts, WHO staff, etc. And those were all participants. In total, they had 265 participants in the first round of the Delphi method, 241 in the second round. And in terms of complete responses, they were able to capture a number of highlights that they then kind of coned down to what are the most important features and definitions of long COVID or long haul COVID. Again, we'll go over some other definitions or terminologies thereof. But at the end of the day, they pointed towards long COVID being symptoms from COVID that persisted longer than 3 months on average. Okay, so that's key. 3 months after initial infection was the definition set forth and arrived by this particular approach to understanding and defining clinical long COVID. If we look to then CDC and their definition of long COVID, we see something slightly different, all right? We see that CDC defines long COVID or post-COVID conditions, as they put it, in a perspective time frame of 4 weeks or more, okay? And that is the definition that we want to use moving forward because it is a definition that we see begins to affect the workforce in regards to their ability to function and do their normal, not just activities of daily living, but obviously function at a level that will protect them in regards to safety sensitive positions at work and or being able to perform work if it's rigorous or high exertional in general. Okay, so again, long COVID, symptoms beyond the initial infection and recovery of COVID that persist 4 weeks or more. Certainly that's inclusive of individuals that experience it 3 months or more, which meets the WHO definition. So it is a conservative definition that will help not miss those individuals that may be suffering from long COVID. So when we talk about long COVID, we want to make sure we highlight one thing importantly as well. This body of data, both CDC, WHO, and others have shown that long COVID can happen to individuals that experience asymptomatic COVID to begin with, right? So even people who did not have symptoms from their COVID infection initially can eventually develop and have right, the conditions for post-COVID conditions and long COVID definition. So again, that a little bit mind-blowing, right? Because one would think the more severe the illness, the more likely you are to experience long COVID, but that not necessarily is what we've found in the data. So we know that this may affect a significant portion of the workforce. And when we talk about different language or different terminology that's been used, long COVID, long haul COVID, post-acute COVID, long-term effects of COVID, and chronic COVID, all refer to the same set of conditions 4 weeks after, 4 or more weeks after initial onset of illness. Okay, so now let's dig into clinically what are the features of long COVID. This body of work that was published in 2021 in the Frontiers of Microbiology found that the most common associated symptom, in this case, 7 months after onset of COVID and recovery, was fatigue. Okay, and so we'll define fatigue a little bit here further as we move forward. But when we're talking about fatigue and post-exertional malaise, those are two different things. They may sound similar, but post-exertional exertional malaise is what workers can experience where they can't perform their normal job. And certainly this is not just with the workforce, but individuals have a moment of exertion and they find themselves not able to persist at that level of exertion compared to their pre-COVID symptoms, right? Or their pre-COVID infection, right? And so we know that this is definitely one of the top issues with regard to long COVID and its effect on the workforce. And potential disability. And we'll hint at that and specifically talk about it in a little bit. Brain fog being number 3. This is something that we presented in this webinar some time ago, the brain fog phenomenon that early on, right, what many thought was not something that was real or organic. But we've obviously talked about the pathology of brain fog and the movement of immune cells into the brain and vasculature that normally don't exist there as a potential cause of brain fog. And certainly in this data, we see that third most common is brain fog for persistence of long COVID. And then we go down the list here. We won't go through all of them. You can read them here on the screen yourselves, but we want to make sure you're familiar with all the different features of long COVID that may be affecting your workforce and preventing them from performing at the level they may have been able to prior to their COVID infection. So why am I mentioning all this? Real quick, right? Because yes, we may be seeing light at the end of the tunnel with regard to our experience, as it were, with COVID-19 and the pandemic over the last two years, right? But certainly we know that the ripples and repercussions of COVID infections amongst the population will persist far longer for years as a result of the tremendous burden of disease that we've experienced. And so we need to understand what that may look like so that we can have processes in place to help mitigate the impact to our workforce. And at the end of the day, our job is to keep our institutions or our organizations thriving with a healthy workforce, right? And so as we continue to break down some of the salient features of COVID-19, let's talk about fatigue. There's 2 levels that we can be concerned with. The number 1 is acute fatigue. So that's what individuals experience while they're infected with COVID-19. You heard, I'm sure, and if you've experienced it yourself, unfortunately, you have encountered the history of, I have COVID, I feel like crap, frankly, and I don't feel like I have much energy. That's the acute fatigue, right? What we're referring to in this case with regard to long COVID or chronic or persistent COVID symptoms, right, is subacute or chronic fatigue, where there may be or may not be associated underlying conditions that contribute to the level of fatigue that an individual experiences, right? And so this is important in regards to understanding how some individuals may be more impacted by their COVID infection because of pre-existing conditions, cardiopulmonary, endocrinology, hematology. So all of these other factors from a health standpoint can contribute in concert to a long COVID symptomatology that may be persistent for an individual. So that's important to know, and we'll talk about mitigation factors there from a fitness for duty standpoint. So this embodies the general clinical features of COVID-19, long haul COVID, long COVID as it were. Now it's time to dig into the pathology, right? So let's understand the biologic mechanism that could be causing long COVID in general. And this will hopefully help you understand that it is real, right? I know certainly there's misinformation out there that may suggest that long COVID is not a real phenomenon that we're seeing, but certainly it is. And we'll try to understand here some of the pathology that may be driving it. So this paper that was published, again, Frontiers Frontiers of Microbiology in 2021, we want to look at then some of the sequelae, which is the symptoms, right? The long clinical features of COVID. In this case, they call it post-acute sequelae of COVID-19, or PACS, all right? And so as we dig into this, we can see that on autopsy, we found that cells have been affected in the CNS, the central nervous system, okay? And this is the first kind of plausible pathology for the fatigue, for the brain fog, et cetera. And we'll dig into this a little bit more here. So it's the neuroinvasive aspect and the neurotropic potential, meaning neurotropic of the virus moving from the bloodstream into the brain itself and affecting the brain. And certainly we've talked about this again in several ways, but we want to look at it a little differently here. And what we find is that the mechanism thereof for perhaps the most impactful long COVID symptomatology, fatigue and the brain fog, the top three rather, is a result of potentially of viral particles that is depicted here that actually enter across the endothelium, meaning that the virus infects, as we know, the vasculature, right? And they can actually infect the cells that make up the vessel walls and thereby then access the brain subsequent to that. And so you can see the little viral particles there that are now in the brain cells that are transversed from the wall of the vessels themselves. Secondarily then, they call it the Trojan horse in this particular article or infographic, where the viral particles, as we know, enter the immune cells, in this case monocytes, and then those monocytes, which can cross the blood-brain barrier, enter into the brain, cause inflammation, and then proliferation of those viral particles, and then those viral particles essentially burst from the cell, right? And that mechanism, again, is one of the plausible pathways for the viral infectiousness into the brain itself, the CNS. So we're talking brain and spinal cord as well. And then the last of the immune response. And this one, again, allows the viral particle to enter across the. It does so because chemokines, they're called, that basically cause the wall of the blood vessel and the blood-brain barrier. There are gaps that are formed, in essence, large enough gaps to allow particles to cross and enter in. Right,
Dr.
which is
Harris, you're breaking up a little bit. I don't know if it's
thank
just
you.
or others.
Yeah, no, I just got a notification that my internet was unstable.
Okay, just wanted to let you know.
Let me know if not. Am I still breaking up now?
Sounds okay right now, thanks.
Okay, perfect. Thank you. Just let me know. And so this is the third pathway by which the virus itself infects the central nervous system and can cause long COVID symptoms. Again, top three plausible reasons for disability in the workplace, okay? And so as we move forward, we want to talk about the second mechanism. We won't talk about the second, third, and fourth mechanism as in depth as the first one, but certainly we know that this is true, that long COVID may be a result of the effect of the virus impacting end organs or multiple organ systems, all right? And we're talking liver and kidney, the lungs certainly. And so we know that as a consequence of the virus affecting these organs, individuals may experience from a result of clotting in those organs or inflammatory processes in those organs, the symptoms of long COVID. And we know that, for example, kidney function is affected by COVID itself. And we're talking actual core function of the kidney, which is the filtrate, right? Filtration of the kidneys is decreased. 35% in one study, 35% of individuals 6 months after their acute infection of COVID-19 experienced decrease in their glomerular filtration rate, right? The classic way to measure how well your kidneys are functioning. So we know that direct impact to organs is a result of COVID-19. We've talked about this before. We even talked about erectile dysfunction as a result of COVID infection, if you recall, right? And that, again, related to the blood and the vasculature being affected by COVID. And then we also want to talk about about, and we have talked about, something called multi-system inflammatory syndrome, MISC, right? We talked about that in context to the phenomena in children, and studies have found, again, in over 10 cases of MIS, 10% of individuals or children demonstrate, right, MIS as a result of COVID-19 infections. And we also have evidence to suggest, again, in this population of kids that experience MIS, 810 in one study, 810 out of 1,075 experienced MIS-C with asymptomatic infections of COVID. Okay, so again, reiterating, obviously the children population not germane to our workforce, but a representative of at what level and what percentage of individuals that have persistent and chronic symptomatology from COVID-19 can experience after an asymptomatic infection of COVID. Okay, so when we talk about the third mechanism, it appears that COVID-19 can persist in certain tissues, right? So it's not a matter of just COVID-19 coming and necessarily being cleared and the inflammatory process going away, but we have evidence to suggest that COVID can exist long-term in certain tissues and continue to cause issues. Now, we've even have evidence, this is not in this particular study, but that the spike protein can accumulate in certain tissues and cause increased risks for different health outcomes and health risks. So again, something that we need to be cognizant of. And finally, we need to be cognizant of what's called immune dysregulation. So what can happen as a result of COVID-19 infections is it wreaks havoc on your immune system, right? And causes your immune system not to function essentially, and I'm paraphrasing this study, to the extent that it normally would to protect you from reactivation in certain cases of other viruses or infections from other viruses. And so what has been found is that there may be increased risk of herpes virus or other viruses becoming more prevalent as a result of decreased immunity secondary to COVID-19 infections in individuals. And that being a plausible mechanism for persistent symptomatology as a result of COVID-19 infections. Okay, so again, I know it's a lot to take in, but we want to go over the mechanisms. We wanted to make sure we captured the mechanisms by which long COVID may affect your workforce so that, again, we understand, one, it is real, two, that it is going to affect individuals. And then right now, we'll begin to talk about to what extent, right? Let's get into the epidemiology. And obviously, I would be remiss if we didn't talk about COVID in general as a precursor to the impact to long COVID. But we want to make sure we do dig into how widespread is long COVID potentially, and then again, the impact to your workforce from a high level perspective. So if we look at how we're doing with regard to COVID-19 in the US, right, we know that 78 million, almost 79 million total cases have been reported. If we break this down to a 7-day case rate per 100,000, that's 144. And this is current data as of today from CDC. So we're approaching still the million deaths from COVID, 947,000, right? And we'll continue to watch these metrics as we move forward. But we want to look at real quick the states that are, continue to be the hardest hit as we stand today from COVID-19, and we'll compare that moving forward to what we'll see with regard to perhaps cases of long COVID, right, and cases of disability in these various states as a result of long COVID. If we look specifically at the US trend and this data that we've been tracing over the last 2 years, we can see that we've had a tremendous drop off of our cases from its peak of almost 2,500 cases per million a day, right, on a 7-day rolling average. But if we look globally, we can see also that so too are other countries that we've been tracking experiencing that same decline in cases on a 7-day rolling average. So again, as I mentioned before, perhaps light at the end of the tunnel. And certainly we know regulatory-wise, we have rolling back of precautions, mask recommendations, CDC even rolling back their recommendations in regards to those who have been vaccinated and mask recommendations thereof. So there is clear indication that the burden of COVID-19 is dramatically less than it has been at our peaks, but we want to be also cognizant of the confirmed deaths per million, right? And if we look at this statistic here, we can see the drop-off has not been as dramatic as the cases here, right? But nonetheless, still, we're seeing declines in the deaths. Hopefully, we'll continue to see the declines in deaths as it would corroborate with the epidemiology data from cases on a 7-day rolling average. But let's dig into the numbers specifically. So I want to call to question here something that has been not just on my mind, but obviously perhaps on your mind as well, in terms of are we truly capturing the numbers, and what is the risk level at this point in terms of where we're at with regard to burden of COVID compared to past times. So if we look right now where we're at, right, as of the end of February 26th, the most recent data in this body of research, we were at 201 cases per million, right? And so let's compare that, right? Because again, we know we're sounding kind of the bells of victory, so to speak, in certain jurisdictions. But if we compare that to where we were in between spikes, we at our lowest point, right, our trough previously back in June, or this is actually July data of last year, we were at 36 cases per million, right? And so certainly comparing now to then, we're still more than 4 times higher than we were then, right? And even then, we experienced another spike thereafter. So I call this data up so that we can ask the question: are we out of the woods, right? There is still no indication that there is protection from another spike from happening, right? We know what, like, for example, with BA2, even though there's no data to show that it's going to spike again with exponential growth currently, the nature of BA2 being 40 mutations different from BA1 predecessor, the sublineage of Omicron, that it does have the potential to cause another spike, right? And so if we have another variant that again can escape the immunity like BA2, that is different enough in which vaccines won't likely be effective, such as BA2, we're not out of the purview of another spike potentially. So I want to make sure we are cognizant of that as we move forward. Yes, we all are experiencing COVID fatigue, myself included. Yes, we want to get back to life as normal, but please be cognizant that the measures that you have in place will need to be something that is maintained in a state that it can be quickly deployed, again, should we begin to experience impacts from new variants as they come, all right? And so now I call the question, is this data accurate that we're capturing in regards to what's being reported? So let's call it the question with CDC's own data, something you're familiar with, hopefully should be if you've joined us before. We've talked about seroprevalence, which is a measure of who across the US, with several surveys that the CDC has conducted over time, have been infected with COVID-19. In this case, the period time span is from December 27th of 2021 to January 29th, 2022. And this data is coming from, in this case, laboratory data in which individuals are tested for antibodies to COVID-19 in all these states depicted here, so that we can estimate of the general population, what are the numbers of infections that have occurred likely across the US. So 43.3% is the number based on this data from CDC. Again, 43.3% of the US population infected with COVID-19. That's 140 million individuals, right? 140 million individuals. Let's go back to the CDC data in terms of what's actually reported, 78 million. So the question is, are we underreporting potential cases to the tune of 50%? Quite alarming, right? But is it surprising? Perhaps not. As we know, the prevalence and utilization of rapid tests have been phenomenal, and they have been obviously a staple in helping us mitigate risk for workplace transmissions. However, right? Rapid tests don't get reported oftentimes. The majority of them do not. So the data that we have in terms of reported cases based upon the seropositivity data from CDC may be underreporting as a result of utilization of rapid tests and other factors to the tune of 50% underestimated number of cases. Right. So that, again, is important to consider in terms of the absolute protection of individuals in the workplace that may be vulnerable. Right. So we keep this in mind. We move forward. Hopefully, we continue to have drawdown of precautions, but we need to be cautious as we do so, as we understand the absolute risk to individuals may be substantially greater than what is actually being reported in communities and more broadly nationwide. And again, based upon national data from CDC. So if we look now specifically at long haul or long COVID data, we can look to a report by the Brookings Institute back in January of this year, January 11th, and it's estimated that, well, they looked more closely at and asked the question, could the labor shortage that we're seeing in the US be caused in part by long COVID? Right. And some of the results are very interesting. This data, though, and the studies that they reviewed as well, suggested that 27 to 33%, again, that 20 to 1/3 of individuals of people that experience COVID-19 infections may still be experiencing a long COVID symptomatology. Right. And so if we take that into perspective, that's 31 million working age Americans. That's 1 in 7 that have experienced and may be experiencing lingering symptoms of COVID-19, again, in the workforce, right? And so that obviously is a staggering number. We'll continue to break that down here in terms of impact. So if we look at additional data, this data coming out of the UK, right? The UK has done in some cases, a more expansive look at this particular issue regarding long COVID than we have here in the US. And they were able to conduct surveys to their general population and looked at the prevalence self-reported wise of ongoing symptoms from COVID-19 in the UK as recent as February 2022, right? This was published on the 3rd of February. And so if we look at the main points here and dig into them, we can see that it's estimated 1.3 million individuals in the UK, which represents 2.1% of their population, self-reported long COVID longer than 4 weeks after their initial infection. So that's key that they use the definition that I spoke to earlier that we want to use, which is 4 weeks, not the 3 months, okay? So that we're conservative in our estimation and don't miss populations that are affected. And if we look at then those self-reported individuals, a good number of them, 21%, had a COVID infection less than 12 weeks previously. They also had an increasing percentage of individuals, 42%, that had a COVID-19 at least 1 year previously. Okay, and if we look at adverse effects on those individuals, 836,000 individuals reported, which is 63%, that they were prohibited or did not have their normal ability to undertake their day-to-day activities, right? Substantially. So when we're talking, again, impact to the workforce, we're talking impact to individuals at the level of ADLs, activities of daily living, as well as obviously being able to perform at levels necessary to, 1, keep them safe at work, and 2, to actually perform their work duties to begin with, meaning that they may be in the umbrella of disability, short-term and perhaps long-term even, right? And fatigue, as we reported earlier in other studies, accounted for the most reported symptom of these individuals with persistent long COVID symptomatology, right? The second was shortness of breath at 37%, followed by loss of smell, 37%, and loss of taste at 28%. Again, these all, the fatigue, the loss of smell and loss of taste, associated with those neurologic impacts that we spoke to earlier, affecting the CNS. And that's part of the pathology there as to why people lose their sense of smell and taste, because it actually infects their brain. We talked about that and presented that pathology some time ago as well. So again, if we're looking specifically at the age range of these individuals, 35 to 69 years were the represented population here in this particular study with the UK, and it spanned across multiple professions, right? Working in healthcare, deprived socioeconomic areas, social care, education, teaching, etc. So let's look at a little different data here in terms of the number of individuals, right, experiencing self-reported long COVID as of January 2022. And this data is specifically looking at the impact of people, again, UK data, after 4 weeks, all right, after their initial infection, going back from May 2021 up until January 2022. And we can see an upward trend there, right, over time of individuals experiencing long COVID, consistent with obviously the burden of COVID as we had Omicron. So again, Omicron not representing or potentially representing still the significant risk of long COVID, even though we know severity at the end of the day from a hospitalization standpoint and death standpoint was not as severe. So when we look at then directly more data, again, from the Brookings Institute as an estimation of the workforce and labor market shortage that we're experiencing and whether or not long COVID could be accounting for it, this gives you a pictorial representation in this graph of what that would potentially look like. Long COVID patients out of work, 1.1 million, and potentially full-time impact at 0.5 million from long COVID, having just reduced their hours, right? So we have those who are out of work and we have those who are not out of work, but reduced their hours, which still contributed to and contributes to the workplace shortage, the workforce shortage, right? And so this is an issue we need to be cognizant of because we need to have strategies to help prevent long-term the workforce from coming back to work, one, too soon when there may be increased risk, and secondarily, trying to get people back sooner that are ready to come back, right? So that you don't have prolonged absenteeism as a result of long COVID. And so when we talk about then understanding and enhancing our approach, we need to have better data on long COVID in general, right? And this is what is reiterated by the Brookings Institute in regards to our overall approach to long COVID in the workplace and in the general population. So what does that look like for us? What's a simple strategy that we could have in place as we talk to and begin to get into the workforce protection strategy for long COVID risk reduction? No, not surprising perhaps, and everyone who knows me and has been a part of this presentation that we want to talk about primary prevention, right? And so let's focus in on that with a simple rubric here in regards to what we should be doing with our approach to help mitigate risk for long COVID. It begins with first, continuing your daily health screen, right? We want to focus in general on how do we promote and maintain a cultural evolution around not just infectious disease and health, but overall general health, right? We want people to feel comfortable, right, letting their employer know, I don't feel well, I'm ill, and therefore I need to stay away from work because I may have an infectious process going on. Again, going back to the statistics on who shows up to work sick, 94% of individuals show up to work sick. So we have to continue to promote those who need to stay home safely, and continuing your daily health screen will not just help with regard to COVID, but other infectious disease that promotes an absenteeism in the workplace in terms of risk, right? Secondarily, then, number two, early testing and identification will still be key in regards to our approach to long COVID, right? So when we identify individuals that have had and tested positive for COVID, the appropriate follow-up, obviously the appropriate identification of any potential disability is going to be key early on, right? When we're talking they're away, not just during their quarantine, but if they are out beyond their quarantine period, having a process to understand that so that, number three, we can enhance our fitness for duty and long-term COVID disability approach. Right, this is something that in the clinical community, particularly even in the health community, is under-recognized as a need to have expertise in, right? If you do a survey of physicians and clinicians that do disability exams and independent medical examinations, you don't find in a list of thousands any that have articulated expertise in long COVID disability. However, again, we know that up to over 1.5 million individuals at this point in time may be affected by long COVID. And certainly that number is higher if we're truly underestimating our COVID numbers here in the US. And so it's something that even we in the clinical community need to deepen our expertise and understanding so that we're recognizing it and we're allowing for processes to help deal with it at the individual level, as well as more broadly at the employer level, so that workers are home safe when they need to be and back as soon as they can be from a functional and fitness for duty standpoint. And then fourthly, continuing to promote vaccination. Why, right? The answer is that individuals who are vaccinated experience less of a viral burden, right, than those individuals who are unvaccinated. And that may be truly the mechanism by which individuals who are vaccinated experience less risk for long COVID symptomatology, okay? Less effect on the CNS, less effect on the end organs, and ultimately a less risk for the individuals who are vaccinated to experience long COVID. So it should be still something we promote in regards to helping protect our workforce from symptomatology and impact from long COVID. So that's it. I know we went through a lot, we captured a lot, but I promised you that we would have time for questions. We have about 15 minutes left or so for our hour. So let's go ahead and jump into it today with your questions. Thank you.
Thank you, Dr. Harris. We have quite a few questions about long COVID, but we promised we would talk in a little more depth about the CDC guideline changes from Friday. So I'm going to take those couple questions first and then get into the long COVID questions.
Sounds good.
One person comments, the CDC guidance changes last Friday feel possibly premature and potentially politically motivated. The new rule that you only need to mask indoors if you are in high-risk area as defined by hospitalization rates versus capacity. What are your thoughts about this change? I would add that for someone who's just looking at the CDC map, which shows low, medium, or high risk, and the variability across those locations and how they could potentially change from day to day could be kind of confusing for folks, unless they're accustomed to just looking at that kind of data all the time. And then there's another question. Is it appropriate for an employer to use this methodology when determining masking requirements indoors? I'm suggesting to leadership that it's not appropriate for a workplace as case rates are given little value. Our job is to keep COVID out of the workplace and our staff well. To me, the use of CDC's data tracker is more appropriate. Please provide your opinion.
I love that question. So let's look at it. If you all can see my screen, that question is referring to this data just updated here recently, February 24th by CDC, looking at levels by county, putting them into categories of high, medium, and low risk, right? And how the CDC actually measures at the community level risk. And if we look at their rubric here, we can see that at the community level, in terms of risk, right, and how it applies to the community, they are looking at cases per 100,000 over the past 7 days, but they are looking specifically at admissions, right, indicators, right? New COVID admissions per 100,000, right? Percent of staffed inpatient beds occupied by COVID-19 patients. That's part of their rubric, right? And if we're looking at admissions here with 200 or more, right, then we're looking at medium and high ranges. So trying to, as the questioner has proposed, not factor it into the low, medium, and high actual prevalence, right, or incidence data for a particular community in regards to whether or not that community is high risk for transmission, right? And again, this is something that has been asked since the changing of CDC's criteria here. And I agree because of how we've done our approach to risk mitigation in the past, that you should still be factoring in your local incidents, right? So let's break that down here. And I know this will be a protracted answer, but I think it's important to cover. So what are the reasons why we should pay attention to incidents? And then what are the arguments against paying attention to incidents, right? Because of Omicron, this all came about because of Omicron for the most part, right? With Omicron, we saw a far more infectious virus, but we also saw a less severe virus. And so what that meant is that we drove up the number of cases, but we didn't have overall the level of impact when we're talking percentage of severity and hospitalizations that we had previously. And so looking at incidence alone became less effective as a means to determine whether or not individuals were at risk for severe outcomes as a result of COVID-19, right? And so what happened is that the criteria was broadened, but still inclusive. And if we look at specifically risk profiles for COVID-19 that began even at the beginning of the pandemic at different performed by different institutions, they all incorporated still some level of incidence data, right? But they added to that the severity factors such as admissions and hospitalizations, and even in some cases, whether or not individuals who were admitted to the hospital were in the ICU, and included ICU data, and included also utilization of supplemental oxygen, et cetera, right? And so there are multifactorial analyses that have been done and put together to look at community risk levels, right? And if we then go back and compare those models to what CDC is proposing, we still see the difference in that there was inclusive data with the traditional models of risk, the incidence. And so my takeaway and my suggestion is to still include incidents locally as a factor in your risk level for your workforce, right? And by not doing so, we may be missing an opportunity to protect the workforce as in a meaningful way compared to if we eliminate that data. Again, when and if we have another variant and it behaves much like the Delta variant or perhaps even more severe in terms of poor outcomes, then incidence data will be, again, something that I believe CDC will incorporate into their rubric of high, medium, and low from a community standpoint. So hopefully that covered the answer to the question. Karen, let me know if there's an aspect of that question that I can elucidate a little bit further.
Well, we'll wait and see if anybody wants a follow-up, but I think that covered it. Thank you. Here's a question about the transition from pandemic to endemic. Do you think the pandemic will reach endemic levels such that companies can stop contact tracing? And if so, do you have any sense of when we might reach that point?
Sure. As we had talked about previously in our other presentations, we looked at this particular issue and asked the question, because there is no clear delineated incidence or prevalence, particularly incidence, right, of COVID-19 that has a consensus around threshold of incidence versus a threshold of pandemic versus endemic, right? That just, as far as I understand, that doesn't exist. However, when we looked at the factors that would play into defining, are we in a modality of endemic disease of COVID versus an experience of pandemic, we looked at particularly the death rate, right? And we looked at and compared COVID to that of other endemic disease, such as the flu. And if we still do so now, we know that the death rate from COVID-19 is still multiple factors higher than what we experienced from the flu. So to get at the answer for the question in regards to when we will likely see the cessation of interventions such as contact tracing, it will not likely be until we see that death rate from COVID-19 closer to what we see from the flu that we can declare we are now in an endemic state. state for COVID-19. Now, is that an absolute? Absolutely not, right? It may exist that we experience a kind of steady state and seasonality to COVID at a significantly higher rate of death than compared to the flu. And it may just be something we have to live with as a community overall. But hopefully, because we have vaccination effective for severity, against the severity of disease and death, we will then have a comparative endemic picture of COVID closer to that of, let's say, the flu.
Okay. I was just thinking about what President Biden announced last night during his State of the Union address regarding testing and then getting immediate treatment on site or at a drugstore or clinic if you test positive.
Yeah, indeed. He did mention that in his address, and we knew that was coming, right? We, months and months ago, looked at the Pfizer pill, the Merck pill. We identified that the Pfizer pill had far less efficacy than was early reported, and once hoped that the Merck pill was likely to be the intervention with its 5-day course that would be used for at-risk individuals at risk for poor outcomes. But certainly what was suggested by the president and what we know there were studies to do and use the medication in a prophylactic way even is exactly what was suggested, meaning that both Merck and Pfizer conducted studies to demonstrate and then apply to FDA for utilization of their medication, even if you did not have risk factors for poor outcomes, or even if you didn't have severe illness, meaning if you only had mild to moderate illness, you were testing positive, you would start the 5-day course. And there will certainly be arguments on both sides as to whether or not that is the right approach clinically to minimize risk, because all medications have some level of risk to them, no matter what. So there will be arguments on both sides as to whether or not that balances the risk reward in regards to the approach to our continuing dealing with COVID-19. But certainly the notion that you can receive treatment, particularly if you're at risk, once testing positive at Walgreens, immediate treatment is a wonderful opportunity to help prevent loss of life for those who may otherwise experience poor outcomes.
Yeah, thank you for that. Maybe we can follow up on that next month. So jumping into some of the stuff about long COVID, this is an interesting question. As you talk about long COVID to individuals who think that with a milder Omicron variant, they want to try to get infected because they think this provides them with better protection. Many seem to think that getting it means they have better protection, but neglect the fact that there are real consequences for some people who get COVID. It reminds me of parents who expose their children to kids with chicken pox so they can just get it over with.
Indeed, and we've heard and unfortunately seen that behavior and approach. And unfortunately, you're right that individuals who don't have any underlying known underlying conditions, otherwise or risk factors, can still experience poor outcomes and death from COVID. Not just long COVID itself, right? Can have a life-ending experience with COVID. And so, exposing yourselves knowingly, willingly to COVID is not recommended whatsoever. And there is no evidence to suggest that natural immunity gives better protection from acquired immunity through vaccination. And so to the contrary, we have data to show the immune response to vaccination is many times more robust, in some cases 40% or 40 times more robust than natural immunity. But we do recognize that individuals after COVID infection will have some level of natural immunity for at a minimum or typically 90 days, and in some cases even longer. But we know that vaccinations are far safer than exposing yourself knowingly to COVID to try to get immunity long term.
Interesting question. Okay, next question about long COVID. Were long COVID effects found to affect persons who received one of the vaccines but did not experience a COVID infection? My understanding is that many of the symptoms presented were attributed to the spike proteins, and those were also produced by vaccination.
So the answer to that is there is no evidence to show that vaccination as a result of the spike protein that's introduced as a result of the vaccination is what causes long COVID, right? If we look at the mechanisms of long COVID as we presented today, the long COVID symptomatology is not a result of spike protein, rather a result of the virus causing inflammatory changes, damage to the epithelium, causing blood clots, etc., and actual end organ damage as a result of the viral response, right? Yes, there is data to show that spike protein can bioaccumulate. And again, if it's both a natural and acquired immunity, you have spike protein involved in both, but there is no acute or data to suggest that the spike protein is a cause in and of itself through vaccinations, the long COVID symptomatology that individuals are experiencing from an active COVID and past COVID infection. We're starting to understand more in terms of bioaccumulation of spike protein. There is a plausible mechanism by which that bioaccumulation of spike protein may cause long-term adverse effects from vaccination. But again, it's a big may. There is no current evidence to suggest that there are health effects, poor health effects from vaccination secondary to bioaccumulation of spike protein.
Okay. You showed a slide related to this regarding the number of people who are absent from work due to symptoms of long COVID. Could you elaborate a little bit more about what you think, how long COVID will affect family and medical leave and short-term and long-term disability?
Certainly. So we, as I alluded to or spoke to during the presentation, the clinical community has been under educated on the parameters clinically of long COVID from my anecdotal experience and speaking with other clinicians. Under educated around clinical recognition of long COVID, and certainly under educated around the disability impact of long COVID. Therefore, two things: individuals, employees may experience an issue with getting and having denial of their disability secondary to a clinician not giving credence to the symptoms that they're having and attributing that to their past COVID infection. So the result in that scenario could be an individual who should not be working from a fitness for duty standpoint, may be put back to work and introduce risk in the workplace that is above and beyond what their risk would be otherwise. Second, on the other side, individuals who are experiencing symptomatology secondary to long COVID are underdiagnosed as a result out on FMLA. And in regards to expedience of the process, may be causing prolonged experiences for both the employee and the employer as a regard to getting to an endpoint of the process, right? And so we will find likely that individuals, as it may be suggested in the Brookings study, that those individuals just simply leave the workforce, right? And so it's something that we will likely see more of, because if we look at Dr. Goddard's estimate of and backed up by the seroprevalence data from CDC, that half of the population in the US would have contracted or will contract Omicron before it's gone, right? And so certainly we'll see more demands on the disability processes for an employer and system in general, clinicians, as a result of long COVID and disability, and delays in getting people what they need to recover, and delays in getting people back from disability back to the workforce.
Okay, well, we're out of time, but there is one point of clarification I thought we could add. When you showed the chart for long COVID symptoms, loss of taste and smell wasn't on the bar chart, but it was on the in the UK data. So is there some reason why it was missing from the bar chart? It's just not that significant, or is it?
Sure. So select sensomotory symptoms encompass the loss of sense of taste and smell. So it's number
Okay,
4.
so that does clarify it. So that someone was asking about that. So thanks for that. So sorry we couldn't get to quite all the questions, but we will do our best to answer them when we post the Q&A. And we'll see you back here in a month. Thank you so much,
Excellent.
Dr. Harris. As always, it's great hearing from you. Take
Well,
care,
thank you,
everybody.
Karen. Thank you. Thanks everyone for joining. Take care, stay safe, and God bless.
Thanks again for joining us.